I think the goal here is to transcend this idea of success and failure, and rather to see each and every experience as a learning opportunity to grow in ourselves. And I think this can, or there's an opportunity for us to apply this in our own professional field, right? Because we have to ask ourselves, what is the goal? And then what is the means to achieve that goal?
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. So this is a continuation from where Dr. Anavekar and I left in the first episode of our mini-series. And for those of you who do not know Dr. Anavekar and who have not listened to the first episode from this mini-series, I highly recommend that you do that. Dr. Anavekar is professor of medicine and radiology at the Mayo Clinic, and he's also the program director for the Cardiovascular Disease Fellowship at the Mayo Clinic. And Dr. Anavekar and I discussed about self-contemplation and self-exploration and how that impacts outcomes in cardiovascular medicine. And sort of taking from where we left, we thought it would be ideal to discuss how we measure success in clinical cardiovascular medicine or in clinical medicine, as well as in academic medicine in 2023, because we've both had discussions about this, and we both feel that we are on the same path as far as measuring success is concerned in clinical medicine as well as in academia. And we think it may be helpful to share our thoughts with the wider audience at Parallax, and certainly the wider audience in general. So with that introduction, Nandan, welcome again on the show, and thank you so much for doing this on a Saturday morning. I can't wait to get started.
Thank you for the opportunity. It's always a pleasure. It's always a joy to reconnect with you. I love these discussions.
Yeah, no, thanks for imparting all the wisdom and all the knowledge that you've garnered through your own examination of self and the journey inward. So I'm going to start by asking you about how you think about success in 2023. And, I think there are two sides of the same coin. How do you think about failure in 2023? And are these even concepts for you? And I think we did broach upon this in our previous discussion, but I'll stop here and I'll have you answer these questions for the audience.
Yeah, absolutely. I think that's a great start to the conversation. And I think that when we talk about the concepts of success and failure, we're talking about outcomes. And if you take a step back, you can really divide our field of experiences into polar opposites, likes, dislikes, success, failure, good, bad, however you want to see it. But they're sort of opposite ends of the spectrum. And what we do is we use that extreme, and within that extreme, we create a spectrum. And that spectrum is what we use to measure. And if we're honest about it, if we look back, if every one of us looks back on our lives, we are amazing at measuring. Even as toddlers, we measure other toddlers based on what they have, right? Who's got the most toys in the sandbox, right? And as we grow older, this measurement schema just becomes more sophisticated. We measure people by what they wear, how they look, what their professional status is, what they have in their possession. And most of these are materialistic measures of somebody's success. And this is really the magnitude of what they possess. Now, in my sort of analysis, and this is again my opinion, and I totally understand and respect other viewpoints. We are no different in our career as physicians. In fact, I think that we measure up to a pathologic level, especially in academia. We have come to a point of our measurement of success is based on numerical values on, for example, how much we publish, what our academic rank is, where we are in the hierarchy within an institution. And even between institutions, the very fact that we have a competition of who is number one tells us that we are driven by these measurements of perceived success and failure. Now, you asked me where I stand in this paradigm. And I, as we talked about or touched about in the last sort of conversation, I think the goal here is to transcend this idea of success and failure, and rather to see each and every experience as a learning opportunity to grow in ourselves. And I think this can, or there's an opportunity for us to apply this in our own professional field, right? Because we have to ask ourselves, what is the goal? And then what is the means to achieve that goal? And primordially, our goal is to take care of individuals who have illness, and by doing so, to help progress the frontiers of our society. Now, I think over time, we have sort of gone a little bit askew in terms of what our goal is, and our goal has changed to seeing how we can evolve in our very own passions to achieve name and status, rather than to align ourselves with the primordial goal, and that is to keep pushing the frontiers of our society by pushing the frontiers of society of what we are, the frontiers of science by understanding more of what's in front of us.
Yes, and how do you think we've gotten here? And I mean, I think you are at a crucial position as a program director, because I'm sure you see this a lot in cardiovascular disease fellowship applications. And, you know, when I was preparing myself to apply for cardiovascular disease fellowships, and I've written a piece about this, which I think I may or may not have shared with you. It's called Perseverance versus Pedigree. And it was published in the European Heart Journal. And this was after I became an attending physician. I thought I should write about this. Measuring to a pathological level, I think a great example of that is cardiovascular disease fellowship applications, because to my understanding, a lot of the applicants are driven by how many papers they've published, the number of papers they've published, the number of abstracts that they've presented, how, thick their resume is, without necessarily focusing on the quality of content that they've, either published or participated in. How do you, I think at a practical level, how do you make that decision or assumption, or what is your thought process when you are screening all these applications? And I'm sure each season you get over 700-800 applicants.
You're correct. So number one, I have to raise my hand and say I was guilty at that time when I was applying for fellowship. I always wanted to consider myself academic, but when I was applying for fellowship, my goal was to get into fellowship, and the means to achieve that goal was to write papers. Okay, and so if I'm really honest, to myself, and in that manner being honest to your audience and your listenership, I have to say that I wasn't aligned to the science of all of the projects that I was involved in, because my primary goal was to get into a fellowship. And I understood how the field worked at that time, and that I knew on my application, the one thing that can be measured and can be looked upon is my number of publications. So I totally get that. And I think that this space has only become more competitive in the numbers game. Now, if we take a step back, I think what's most important and what I think causes more division is even the definition of academic. And I don't know whether you have a definition of academic. I know I've, in the last couple of years, tried to find a definition in Western societies of the term academic, and I haven't really come across anything that's precise. In fact, I think that you could find two definitions that are polar opposites. One, that academic is any discussion that is of theoretical interest, and on the other end of the spectrum, academic can mean anything that is of educational value. Now, when you apply this to our profession, because we all talk about being academic cardiologists, right? But if you don't have a precise terminology, and we use the term loosely, then I think that this leads to the development of prejudice, right? And I think we've all been involved in conversations where we've heard sentences like, so-and-so is more academic than so-and-so, or this institution is more academic than this institution, or, book chapters or review articles. That's not academic. To be academic, you have to be involved in basic science or lab research. But who defines the threshold of what's academic? And I think without that precision, we lead to prejudice. And without that precision and with prejudice, I feel that it is next to impossible to make a real coherent, accurate, and sufficient measurement of any applicant that is trying to find their way into fellowship. I absolutely believe everyone is well intended. I think everyone who applies, every 800 applicants, have a strong desire to be the best that they can be in that fellowship, whether it's cardiology or whether it's GI or any other fellowship. And I also believe in my, heart of hearts that they want to be academic. However, I don't think our profession has done the right thing by these youngsters in defining what that term is. And to be honest, the only area that I've found a precise definition is in the philosophic literature.
Yes. So, when you mentioned that you'll raise your hand and you'll say that you were guilty of this, so was I. And, I've sort of written that in the paper that I published in the European Heart Journal. And I concluded that, pedigree is not defined by the institutions we work in or we serve for or have our names attached to. I think pedigree is a concoction of hard work, the ability to be self-critical, perseverance, and dedication, and the focus to go deep into any topic. That's what pedigree is. And as long as you have those values, as long as you have those human qualities, that's what your real pedigree is. It's not where you belong, or what institution you're affiliated with. And I think, this goes back to, theological literature and also philosophy, that the true definition of an academic, the Bhagavad Gita, actually mentions that deep study of any topic is akin to meditation, is akin to finding God, is akin to academia. So you could be an academic anywhere on the globe. I think it's just that mindset that you carry as an individual. That's what I think when I think of academia.
I totally agree, and I'm glad that you brought up that philosophic sort of purport, because it is so precisely defined. Because if you accept knowledge, so this is the school of thought that you've sort of brought up. If you accept that knowledge is neither created nor destroyed, and if you take a seeker of knowledge, and that seeker is somebody who tries to understand the world in front of them, then that seeker is called the academic. And the academic is defined by one who tries to understand what's in front of them, that deep understanding. And number two, who tries to preserve what is already known through teaching. And so that's that teacher-student relationship and the discovery of new knowledge. And then the third component of that is to utilize that in a practical manner to take care of the world that's around them. That means taking care of each other, taking care of nature, and you can extend that to other sort of aspects of society. But I think, as you pointed out yourself, there is a precise definition, but we haven't been using it, and instead we use a more loose definition, an ideal concept that I think leads to more division than unity.
Yes. So, Nandan, for someone who's listening and who is a prospective applicant to a cardiovascular disease fellowship program, which both you and I know is very competitive, and he or she will be like, okay, this all sounds great, and thank you for having this philosophical discussion and conversation. How do you distill this down to the practical aspect of things and the process, and what are you both doing in your capacity to make this a more fair process for the applicants? How are you going to respond to that question? Because, we both know that the practical end of things, unless you have a buffed up resume, you're not going to be considered competitive. How do you reconcile with what you now know with what the reality is?
I'll tell you this. I can't speak for every program. I can only speak to what I've done. And part of that is a perspective of being a foreign graduate myself, and understanding that, how difficult it is. And by no means has my path personally been, extremely difficult in any way. What we do, is we look at every application, that comes through the door. So if it's 800 applicants, we read every single one of them. There's some things that we just can't escape, right? There's some metrics, like, board scores. We look at number of publications. We look at that. You cannot escape that because that's part of the application. But the other part that I look at very closely is the personal statement, because as you said, pedigree is not, an institutional affiliation, but I also like to look at distance traveled. I've been sort of flawed. Sometimes I get a lump in my neck when I read some of these applications of these kids that are supporting their own, their siblings or their parents, taking a second job, all the while getting through medical school, and to try to make something of themselves, and driven by their passion, to become a cardiologist. Now, those individuals may not be at what is typically or traditionally considered a top tier or premier institution, but they have traveled such distance not only geographically necessarily, but also mentally, the mental obstacles and hurdles. So these are the non-substantial or the subjective or the qualitative parameters that I look for in the applications to help me dive deeper to get to know that individual applicant. Now, with all that said, at the moment, I don't think there is an entirely fair process because, something or fairness is based on perspective, right? So the spelling bee is only fair when my kid wins the competition, right? Otherwise, it's unfair. And I think that we'll always see a component of unfairness whenever an outcome doesn't go in our direction. The other major limitation is that of the 800 applicants that are out there that are applying, to any particular program, we're unable to interview all of them. And I think that's just that's a tragedy, right? I wish we could, because I have no doubt that, the vast majority of applicants out there would do just fine in any fellowship program. But these are the very real limitations that are out there. And I think that we as leaders, program directors, associate program directors, departmental leaders, those in our societies in ACC, HA, European, Cardiovascular Society, I think we need to take a step back and recalibrate what is important. How can we as physicians be more reflective of the problems and priorities in our society as it pertains to healthcare? And that's a big lift. And again, with big lifts, I think we have to start very small, and inch our way forward.
Yes. So I'm going to bring this up as a question, because this question has resurfaced in my own life. As I've traversed across institutions, and that question is, as an extension to physicians being thinkers and how we want to evolve as a cohort of physicians who are, forward thinkers and who have always changed the paradigm in ways things are done. Cardiology has always been at the forefront of innovation. So this is sort of a thought innovation question, and that this question is, how do you think about the publish versus perish mentality, which I know I've had, and I'm, maybe I still have that residue. And knowing what we now know and how we've now evolved, thanks to theology and philosophy, how do you reconcile with that question? And when you are invited to be an author on a paper, or, when you are thinking about a project yourself, or, trainees who approach you with projects, what do you now think when you are thinking about projects to do, which, obviously would be important, very important for the trainee? I think any project that a trainee gets is so important for them, because, they're just starting out as clinical investigators, and they have well-defined goals of getting X, Y, Z number of papers published before they apply. So how do you balance that need or demand? It's a situational demand for them, and they're dependent on you as a trainee, and they have faith in you. They have belief in you. So they're sort of putting themselves on the line when they are entrusting you with their responsibility. How do you balance that with also moving the field forward and doing, pushing the frontier science rather than publishing another paper science?
I think that's a great question, and I'll sort of explain how I sort of work on project developments with residents and fellows that I work with. But before that, I think it's what astounds me is the fact that the number of cardiology related articles that are published every year. I think it comes somewhere close to 30,000, and I'd invite you to fact check that. But I think that, because I recall there was a paper that came out maybe in the last year or so looking at sex disparities in authorship. And I think they quoted something close to 30,000 cardiology related articles per year. Now, if you take a look at that, that means that if we read one original article or one article per day, we'd be reading less than 1.5% or 2% of the annual literature, right? So which means we will never be able to keep up with that if every part of that literature is of impactful nature. And so, yes, we are publishing at an exponentially, great rate. And the question becomes, of everything that is being published, how much different has our practice been? And if I look at my sort of career as a cardiologist, I think the most impactful area for me that has really changed has been the advent of percutaneous structural heart interventions, valve care, with aortic valve being the first on the scene. And I think that has been impactful. But if you look at 30,000 potential articles per year over the last 10 years, that's over 300,000 articles in that time. The only thing that has really changed my practice, in a most meaningful way, is understanding of, a new way of managing valve disease. Now, of course, a lot of other therapeutics have come, but not at a rate that requires 300,000 articles over a 10-year period. Now, when we come to individuals that are looking for guidance, want to get involved in writing and in research, I think there are different strategies, and I can only attest to the strategy that I participate in. I tend to work in groups, so try to be as collaborative as possible. And when a trainee comes to me, what I first do is I have a meeting with them first and say that whatever project we do, I want it to come from you, because that's going to be the project that you're going to be passionate about. Because if I just plug you into ongoing projects, you're going to just be going through the mechanics of it to get that paper published. And I understand for some, that's all they're interested in. And I accept that. But for those who want to carry a project, passionately forward, what I tell them, especially to those who are novices, who don't have much research background, I say, look, go pick up any cardiology textbook, look at the contents page, pick up a chapter that interests you, read it completely. Once you've read it completely, write down a few questions that come to mind that haven't been answered in that chapter, then go to the guidelines, read them completely, see if those questions have been answered. And if they have, fantastic. See what new questions come up. Then after you've done all of that, let's visit, and then let's see what questions remain. And then based on those questions, we will try to figure out, can we find an answer for it in the literature? So we're not trying to recap or reinvent the wheel. And if we can't, then I think that presupposes a potential research project. So I am definitely not, publishing at a rate of, 2 or 3 articles a month or anything like that. I don't consider myself prolific. I think being academic means staying in touch, trying to understand what's in front of us. I try to be led by the questions that really do disturb me when I'm looking after patients in the CCU, or if I'm coming across something unusual when I'm in the imaging suite. And then I use those questions as the springboard for potentially writing. And I also see that writing as another way of keeping in touch with our peers across the globe. And that's what I try to introduce to the trainees that seek my guidance. And so it's not necessarily, a prolific multiple paper type of a venture, but it's a slow and steady, and see how you go. Some trainees really enjoy the experience. Others discover that it's not for them. Others discover that, they are so much more detail oriented, and they want to be in a lab and they want to try bench research. And I think that experience, that exploration is fundamentally what I go for. And if a trainee discovers that this is right for them, fantastic. If they discover that it's not right for them, I think that's equally valuable. But that's sort of how I personally do or approach the space of publishing or being involved in research projects. I also consider writing book chapters, review articles, opinion pieces. I consider that as academic as well, because it's delving into understanding a topic and being able to teach that topic. So I consider those areas of participation or activities as equally academic.
Yeah, no, I agree with you. Actually, book chapters and review articles are some of the most arduous and laborious projects that I've taken, because writing a review article is exhaustive. And I mean, this is by no means a plug or a brag, but just to impress upon the value of academic nature, if you're putting a review article together, we had embarked upon a mission to better define cardiovascular risk in South Asians with a group of clinical investigators in India back in 2019. And we wanted to, I think we had discussion with circulation editors, and this was part of the Cardiovascular Science India tour, which was organized through my nonprofit, where we took editors of circulation to India, and we toured a private hospital. We toured a public teaching hospital, and we toured a basic science institution in New Delhi, and we wanted to foster, just new and innovative research from the region. And then as part of that discussion, we decided that we will write this comprehensive, exhaustive review, almost like a seminar for understanding heightened risk for atherosclerosis in South Asians, and particularly in Indians. And so we embarked upon this project in 2019, and through iterations and submitting this to Circulation and other journals and going through the process of revisions, it took us 4 years to get this paper published. It has over 100 references, and it's one of the most exhaustive pieces that I've written. It's out now in Lancet Regional Health for Southeast Asia. But the amount of work it took to get that paper to see the light of the day is more than some of the original research papers that I've written, which have been published in higher impact journals. So, by no means the effort that goes into writing a book chapter or, putting together an exhaustive review is less. In fact, it's a lot more in my own experience.
I totally agree. I totally agree with you. But it brings to light that without a precise definition of the term academic, you can see the prejudices, right? I mean, it's not uncommon for me to hear, individuals amongst our professional sphere indicate that, look, book chapter is not academic at all. So I've heard blatant statements like that. And I think that's the problem. And without a precise definition, the efforts, the magnitude of efforts, and the essence of wanting to understand, what's in front of us and to make our profession better, it leads to more division. Because I totally agree with you. I think I learn more, I understand more when I am putting together a book chapter or a review article, because you really have to become, savvy with the literature that's out there.
Yes, and you sort of are almost an expert at the end of that exercise, because you've yourself reviewed all the literature that is out there, and you've synthesized it. And it takes a lot of understanding, deep vertical understanding of that particular topic to have to review all the literature that exists to synthesize it, and then to put it together in a format which eloquently summarizes everything that's out there until now, and then identify gaps. I think that takes a tremendous amount of exploration. It takes a tremendous amount of understanding, and then it takes a tremendous amount of effort to summarize it. I think putting a review article or a book chapter together is by far the most academic activity, in my opinion.
Yeah, I would agree.
Yeah. So after having gone through that exercise, with this particular paper, in terms of effort and in terms of the quality of effort and the purity of effort, I don't think I've done that kind of effort in any other paper, even though this is published in one of the sister journals for Lancet. So the impact factor, if that's how you measure the success in academia, yes, it's not that high of an impact factor, but to me, who has also published in the more popular journals with very high impact factors, this particular paper is very dear to me because I know the amount of effort it took to get this out there. So I agree with you. It's very ambiguous how we very superficially measure, what people have done, in their careers by just looking at, where they've published this, or what's their H index, or what is the impact factor of the journal where they've published this. I think these are all very superficial metrics. Impact is a lot more, and you really have to read each paper to understand the quality and the effort that has gone into a particular writing, in my opinion. Nandan, I think, as we are approaching the close of this this particular episode. And there's more to come because, we have this mini series coming up for the audience who are listening. How do you want to see this particular aspect within cardiology and medicine at large change? And what are some of the measures that you have taken as an individual who belongs to, a very powerful institution within the realm of things, the realm of things cardiology? I mean, you belong to an institution which is revered and looked upon. And you are at a position where you can usher in change not only through things you do on a day-to-day basis, but also you are at a position where you can foster new concepts into avenues where people will read those, thoughts that you put out because they're coming from someone at the Mayo Clinic. So I think, how do you envision changing that? Or what do you do? Or what have you thought about doing to change that?
Yeah, I think that's a really it's a powerful question because what we've been discussing, a lot of it is based on perspective, right? And so whatever perspective I have, I think the wise thing to say is that perspective is mine, and I have to accept and respect that there are going to be a lot of other perspectives that may be counter to mine, and I can wholeheartedly confirm that some of my perspectives, even within the institution that I work with, are not going to be universally accepted as the ideal. So that being said, I think that one of the largest lessons that I have ever learned through my experiences as a physician was actually not during my sort of workday at Mayo Clinic, but it's during some of the volunteer activities at the Salvation Army Clinic. And what I learned there is that as a physician, I may have a certain set of priorities, and it might be that I get my patient on all 5 or 6 or whatever number of guideline or goal-directed medical therapies for a particular diagnosis. Now, when I use that set of priorities to drive my decision-making, then basically what I'm doing is that I am prioritizing my end goals over the goals of the patient. And that realization came to me extremely expeditiously when I was looking after, patients at this volunteer clinic whose priorities were absolutely unaligned with mine. And so, for example, a patient may have 2 or 3 jobs to make ends meet. And so with a finite number of dollars in their pocket, they have to prioritize paying the rent for an apartment, paying for food on the table, paying for tuition for their children. So those are real priorities, and those priorities may take a front step to the priorities of being on certain medications for a diagnosis. So what I've learned is that yes, we are great at making diagnoses. We are great at prescribing medicines. We are not great at understanding our patients and our patients' priorities. Now, that's at the individual physician-patient interaction. At the societal level, I think that there is a risk of us being siloed, especially at these big meetings. And I know that, and I congratulate the efforts made by our societal leaders at ACC/AHA on the US front to try to understand the societal needs better. But I think we need to calibrate or recalibrate those priorities when we start talking about guidelines, when we start talking about our sort of measurements of therapeutic success when we're dealing with our patients, because without taking into account these other interacting factors, we're not really reaching our patients in the meaningful way that we all want to reach our patients. And again, this is my opinion. Now, how do we affect those type of changes? I think it's hard. I don't have a solution. I don't have a robust hierarchy of an approach. I can only attest to my approach, and that's on a day-by-day basis. When I'm in the CICU, I try to emphasize the importance of understanding the social history of the patients, trying to work with them within their capacity. Only last week when I was in the ICU, we had a patient who could not tolerate guideline-directed medical therapies, and I, wrote in my note, we will aim for or aspire towards monotherapy with diuretics, with the goal being to alleviate congestion and to make the patient feel better. And surprisingly, most of my team were aghast. They're saying, so we're not going to try to get Entresto back on, or we're not going to try an ACE inhibitor or spironolactone. And I said, look, we can try if the goal is to make ourselves feel better by having the patient be on these medications. But this particular patient was in the CCU. We got the patient out of the CCU onto the ward service. Attempt was made to start like minuscule doses of these guideline-directed therapies, and the patient has ended up back with us. So we have to recalibrate. Why are we doing what we're doing? Because the goal for the patient is to get out of the hospital, to be with his family, and to do what he can, in terms of participating in his life. Whereas our goal may be askew to that. And I think that we need to recalibrate this at the bedside first. And then from that ripple, hopefully this starts creating a wave, and that wave may hopefully affect change. But this change cannot happen unless we have a discussion, unless we have a conversation, unless we make time to do that. And as you know, very well know, we're all pressed for time, right? We have noon meetings. We see extra patients at the end of the day. We are all stretched thin. We all wear different hats, and there's not enough time in the day to meet each of those expectations meaningfully. So I struggle with this. I really do, Ankur. I don't have a great solution apart from trying on a day-by-day basis, on a patient-by-patient basis. And I will be honest with you. I have missed many opportunities in having these conversations. I foresee I will continue to miss opportunities, but I can do my best, to make the best of those opportunities when they arise. And I hope that my trainees do the same and grow from that experience.
Yes, I think it's the perfect way to end this episode, Nandan. I think we will pick from here in the third episode of this mini series, contemplative concepts, and thank you for sharing these thoughts so openly and being vulnerable. And I couldn't agree with you more. I think we have to start measuring our success in terms of how we made our patients feel, and I think that's where the importance of implementation science comes in. And I know that societies like the American College of Cardiology and the American Heart Association are trying to get more funding in for implementation science, which I think is going to be the next frontier of clinical investigation. Because we can have all the drugs which have all these amazing outcomes, but if our patients are not taking them, either financially or just the fact that they can't tolerate it, it's a lot of effort, a tremendous amount of effort, millions of dollars, if not billions, goes into waste. So, thanks again for joining me this Saturday morning to do this, and we'll be back again with the third episode of the miniseries. And thank you to everyone who's listening. If you haven't had a chance to rate us and review us, please do so. On Twitter, on LinkedIn, also on review tabs for Apple Podcasts, SoundCloud, and Spotify, among other podcast platforms. We take your feedback very seriously, and it helps us refine Parallax and also get guests on board from whom you want to learn from. So with that, thank you everyone, and we'll see you back next Monday.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.